I said, I kind of know that when we've got a really good topic, because my relatives pay attention to it, and uh, the my mom and my aunt both said, "Wow, the topic that you have this Friday really sounds very interesting." And so I couldn't agree more. And I am really thrilled today to introduce you all to Christine Bitzer, who is with the Seabury Resource for Aging Care Management uh, organization. I give Christine full credit for coming up with this great topic and pitching it to me, but it's really not only is it a great topic, but this is a great partnership with Seabury Resources for the Aging, who's a positive aging community champion. But you have a anniversary coming up as well, right, Christine?
We do. So, as you know, the larger nonprofit organization, Seabury Resources for Aging, is over 100 years old. But my program, Seabury Care Management, is turning 30 this year. So we're excited about that anniversary this year, um, and all the celebration and hoopla that comes with it.
I love it. And for those of you who aren't familiar with Seabury, I'm just dropping their website into chat. But Christine, before we dive into this very important topic today, let's get to know you and Seabury a little bit better. Tell us a little bit about your background and familiarize us a little bit more with Seabury and your role there.
Yeah, sure. So, I have been with Seabury since 2009, so I'm also coming up on some anniversaries here. Um, I started there as a care manager primarily because I was a social worker who really wanted to work with the whole person and be able to dive in and build that relationship with those individuals that we're working with. So that's what drew me to Seabury, which, as you know, back then was ESM, and we were called ESM Cares.
I remember.
So it's been quite some time, actually. The and Seabury Resources for Aging is really a wonderful community. We started as a housing community, and have since just really grown from there. I believe we have 8 or 9 different programs, and I'll certainly include those on the slides that will be available to people. But all of those programs kind of fall under the pillar of good housing, good community, good food, and good resources. And this feeds into Seabury's mission of being an expert in aging who can really provide that personalized, affordable housing and services to the DC area adults. Our goal is to help people age with independence and dignity. And in care management, we're really looking at the quality of life of the people that we work with. Um, we try to keep our rates affordable. We are a nonprofit, so we also have an equity fund where we can reduce those costs. But it is about counsel and advocacy done by the care managers, and then also through our life enrichment program, supporting the older adults who may be aging in place, may not be getting out as much as they used to, or being engaged. So combating that social isolation, just through interaction, whether it be going out on trips or staying in place and doing, movie nights or book clubs, that type of thing. So that's
I
what we
love it.
do.
All right. Well, what a great intro. And I don't want to delay getting into your program anymore. I know you've prepared a slide deck, and if you want to share that, and what I'll do when I see that it's up there is I'm going to drop behind the curtain. But folks, the for those of you who have never been to one of our discussions, these are very interactive. You can ask questions, you can make comments, you can share resources. And so, Christine, feel free to take a break if you want to just check in with me. And if there's a few questions that that are relevant to what you've already said, we can address them. But otherwise, take it away. And then, folks, just throughout the event, if you want to just throw into chat or Q&A any questions or comments that you've got to share, we'll make sure to address those when Christine gets through the slide deck.
Yeah, definitely. As most of you know who have seen me speak before, I do like things to be interactive and engaging. I think, we learn from each other and we kind of push forward my topic here. Um, as you know, with managing the crisis and advocating in the medical setting, we could go on and on forever about this. But I thought the best way to do this might be to, first of all, define what a crisis is and what are the roles of being an advocate. I think we all have an idea in our head what advocates are. But there's really more than one role within advocacy, to my mind. So we'll go into that a little bit more, and we'll talk a little bit about what to do before the crisis. You'll see that a lot of this is about knowing what's out there before you get out there or before the crisis hits, because ideally safety is the biggest concern, and so ideally we don't get to the crisis, or the crisis is less than it would have been. We're all going to run into these bumps in life, no matter what our situation is. It's a matter of, I often tell people, it's kind of about putting out the mattresses and making sure that we have a safe place to land. I thought it would be helpful to do some of this by talking through scenarios. Again, these are made up things, but they're a collaboration of, or a conglomeration of different things that we've seen on our information line and obviously with our clients before they become clients and when they're coming to be with us. And then also just then talk about kind of that recalibrating and getting started. So a crisis is not something that happens over and over again. We often see people coming into our services or calling our information line after something has really become more chronic. During a crisis, you'll find that there's a lot of needs. This is a time that's physically and emotionally draining. There's a lot going on. There may be a lot of physical pain, a lot of physical challenges. It's also going to be an emotionally charged time. For an older adult, it can be a time when you have some big emotions. There may be some sadness, some anger, some grief, a lot of anxiety. A lot of this, including with the pain, can provoke some more anxiety. It's going to take a lot of time. Even if it's a short period of time, you'll find that that time just takes a lot. It's, having somebody go into the ER usually is an all-day affair. We just know that automatically. As soon as a client calls and says that they're heading to the ER, I know I'm going to be there for several hours, at least, if not the rest of the day. Financially, there can be a lot of high costs that are going in here. You have to remember that a crisis is a kind of a signal of when things are not working any longer. Something needs to be adjusted. So I would challenge you to look at this as an opportunity. It's just a little warning sign. And again, if something becomes chronic, it happens again and again. It's no longer really a crisis. It's something chronic, and that is not sustainable. You can't sustain that kind of emotion going through. You can't sustain the physical challenges, the financial challenges. So it's really important to mitigate the risks so that it doesn't become chronic. It may also be the time to contact a professional, like a care manager. First of all, we've probably seen something similar before. I think single situation is unique. There's always going to be something new to learn from it, but I've probably seen something similar, and my colleagues in the Aging Life Care Association have probably seen something similar that we can help you work through. We know some of the questions to ask. We also don't have that emotional tag, or as much of the emotional tag. We're often very close to our clients, but at the same token, it's very different. You know, when this was happening to my parents, completely different story. It doesn't matter that I do this professionally. There's always going to be something different when it's a family member involved, or if it's a neighbor or somebody. Those emotions are just different. So this might be the time to come to get that professional help. Advocates. I think there's a lot of roles for advocacy. When I hear the word advocate, I usually think of somebody who's very strong and forthright and might be willing to make a big stink and everybody sees it. But that's not necessarily the only term for advocate, and sometimes that actually doesn't work very well. Um, it is somebody who can help you navigate the healthcare system, being able to maintain contact with the medical staff. So perhaps making sure that your primary care physician knows that you're in the hospital or you're in rehab and the changes that have happened so they can get there. Being in person at the hospital to be able to talk with the staff, keep notes. This can even be, if it's not a crisis and you're going to a healthcare appointment, just somebody who's objective. Remember, if you're in a crisis because there's some sort of medical need, you are probably not functioning at your top level. It doesn't matter if you have cognitive impairment or not, you're ill, you're in pain, you're not going to be taking in half of what they're saying to you. And also, if you're in the hospital, we know that when you stay overnight in the hospital, there's a lot of things that have to be done. There's a lot of tests that have to be run. It's not really on your schedule, it's on their schedule. It's when the MRI machine is available. And if it's available first thing in the morning, and you don't normally get up at first thing in the morning, you're going to be up, or they're poking and prodding you. So that type, you need somebody there who can take those notes and remind you of what was said and discussed. It could be that that person is your healthcare agent, so your power of attorney. And I know Steve has a talk coming up about that, so that might be a good one to listen to if you haven't decided who's going to be your healthcare agent yet. It can also be just about being supportive and comforting, being able to be there with the person. I know sometimes when we're sick, we don't want anybody around, but we want to make sure, we want to know somebody's close by, right? Making sure that somebody can say, you know what, they haven't received their lunch yet. Could we get some lunch in here? And by the way, they eat kosher. Is there something that fits into that diet? Are there friends and family who don't know that they're in the hospital and they would like to come and visit? You know, certainly I've had things happen to me where people say, "Oh, if I knew, I would have brought you a meal. I would have done something else," but they didn't know. Another thing that's in the supportive and comforting piece is what's happening at home. You know, do you have a fur baby at home that nobody's taking care of because you were whisked away to the hospital? Is your mail being checked? Is your rent being paid? If you own your place, are your condo fees, and you're in a condo, are your condo fees being taken care of? All of these little things that kind of get put on hold if you go into a hospital stay that might roll into rehab or something else. And these are all advocates. So, where I want to start is to say that we really need to be educated before the crisis starts. So, for example, if you have a new diagnosis, What are the treatment options? Do you understand what the prognosis is for that diagnosis? Do you understand what the trajectory is? Do you need a second opinion, not even necessarily to confirm the diagnosis, but just to get a new perspective or a different perspective? What can we learn from each other? You heard me say at the beginning of the talk, I'm a big believer in all of us being able to support and educate one another. So, what can you take from others who are already on this lived experience path? Um, are there support groups? Are there diagnosis related organizations that you can get to know other people? Again, I'm not saying that their situation is going to be your situation. I often hear that, I have MS, but it's not the same as what Steve has. It's not the same what Joe has. No, absolutely not. It's not. But are there little nuggets that you can take from one another? And again, we do this throughout life. One of my former directors and I used to talk about this all the time with regard to aging. We have books, we have other things about getting through X, getting through Y, getting through raising children. But as we're getting older, there aren't necessarily the same supports out there, or they're harder to find. So that's where I'm kind of saying, learn from others, take your nuggets. What is your support system? I had somebody mention to me when I was preparing for this talk. They said, "Well, I want to hear your talk, but I don't want to hear about self-advocacy because you cannot do this by yourself." And I said, "You know what? You're absolutely right, and that's why I wasn't going to talk about self-advocacy. There is a place for self-advocacy, but if you're not feeling well, who is around you who's going to be able to help you with these things? Who are the people who know what the code is to get into your home, or have a spare key to get into your home? Who knows about what your culture is and what you would like to have in place, what you need to have in place? Who understands your beliefs and can speak to these things that happen, potentially even near the end of life? Um, who's going to be managing those finances? So understand what your insurance will pay for. I'm going to hop into these scenarios, but I thought I would just stop a moment and see, Steve, if any questions have come up that can be addressed. I don't.
Well, nothing specific except for what I love is Brian's comment, who was saying that he recommends using a website called caringbridge.com as a private social network for people to come together. And I couldn't agree more. There are several of these apps out there that can help rally the troops around somebody who may not be feeling well or in the hospital.
Yep, I totally agree. And some of these apps will even have calendars attached to them that you can like do that meal train, or have, if somebody's in the hospital and they haven't come home yet, have visitors coming in, um, just to be able to wrap that support around someone. Yep, totally agree.
And this is good. Stephanie actually has a good question that maybe you could answer, and then I'll jump off and we'll get the rest of them. She says, what kind of notes should advocates be taking in a healthcare setting?
Yeah, I mean, I think just writing down the information that the doctor is saying, ask, first of all, the best place to start is to have your list of questions ahead of time. What are the things that you need the answers to? Now, what is the situation? What is the plan? I think, one of the things as a social worker that we're taught, in whatever, if you're in medical settings at all, it's you immediately start planning for discharge. Because as you know, in the medical setting, that's the first thing that the discharge planners and the social workers are working towards. So what is that going to look like? Having information about what, and I'm going to go into this in some of the scenarios, but having information about what your home looks like, where you came from, so that you can talk to the physical therapist or the occupational therapist. Of course, my phone starts ringing, about what's happened. Let me just stop and get off that. This is the joys of working from home now. So understanding what does your home look like so that you can return to that. When should you be expecting different people to come in? When will the therapist start to work with you? What are some changes in medications that are happening? All of those
Love it.
pieces.
I love it. I'm going to drop behind the curtain, and folks, just keep good questions coming in, and we'll have a great discussion when Christine gets through her deck.
Okay. So this is a pretty typical one, and I've already started kind of diving into some of this. Um, Again, kind of what we see of a conglomeration of people. But Mrs. Smith went to the hospital. It took a lot of time to find her. Nobody had realized that she had fallen, and she didn't have a personal emergency response system that she could press. Her daughter is her only child and doesn't live in the area. So for many practical reasons or purposes, all practical purposes, she is a solo ager in some ways. The EMTs actually had to break into the house to see if she was okay. And when she went to the hospital, she didn't have anything with her but her phone. I mean, thank goodness she had her phone. As I mentioned, her daughter lives out of state, and her daughter didn't have access to her information. Of course, she'd been on the floor for a while, so she wasn't very coherent. She was in a lot of pain. She couldn't really report about her diagnoses. She couldn't explain to her daughter what the doctors had said. So there was a lot happening here. And one of the things you want to make sure of is that you have a list on your refrigerator of your medications, of your diagnoses, your doctors, who are the emergency contacts you have. The other thing you may want to consider having available right there is to have what's called a physician's order for life-sustaining treatment. And in this area, most of us will know this as a MOLST form or a MOST form or a POLST form. Every state gets to call it what they want, but the larger federal is the POLST. And this essentially gives a quick synopsis of your advanced medical directive so that the EMTs have an idea of what your wishes are depending upon the situation. Certainly, if you are in the hospital or in a rehab or an assisted living, they're going to get that information and put it on their own form, but it's good for you to have it in your home if you live out in the community, and make it available for people. How about this breaking down the door? That's an expense you didn't plan for. That's also something that's not fun to have happen. I know we can all have different answers to that question, but one of the things you can do is consider putting a code on your door. Consider giving that code to someone else who can have it available if needed, giving a spare key to someone, calling the fire department, the non-emergency line, and asking them if they have a system for this if there's an older adult living by themselves. Some areas do have systems that they know where to go for some of the information. And nothing is 100%, but knowing what are the possibilities. So again, preparing for that medical crisis, so that you can ask the questions when you get to the doctors, when you get to the hospital. Having somebody, again, designated to take those notes or to review the paperwork. One of the things that we've seen quite frequently, again, this has been the standard for quite some time, but it's within the time that I've worked at Seabury, this observation status versus admission status. And ironically, I just had this come up on the information line sometime in the past couple of weeks, where a family was saying, well, the physical therapists and the doctors and the nurses all say that mom should go to skilled nursing. But she had only been there a day, and the plan was to get her out as quickly as possible. And I asked if she was admitted or under observation, and the daughter couldn't answer that question for me. And she said, well, does it really matter if if all of her providers are saying that she should go to skilled nursing? It does, because Medicare won't pay for it. You can go there, but Medicare won't pay for it unless you've had a 3-day or a 3 midnight stay in the hospital setting. And again, when we're talking about rehab, it's typically, in this case, we're talking about inpatient rehab in subacute care, which would be what we often say is a nursing home. And I'll go into that a little bit more later. Have somebody there on site with you at the hospital. There are things that we can do over the phone, but unfortunately, there's so much going on in the hospital. The providers there are so busy that you can leave messages and they may not be able to get back with you, or they may not catch you. I mean, I just had to make a call for one of my kids. And of course, when they called, I was in the middle of an appointment with a client, so I couldn't pick up the phone. And now the response is, well, set up an appointment with me. If I had been able to be there in person, I would have been able to talk with the doctor and get the information immediately. So is there somebody who can take notes as the doctor is rounding in the first thing in the morning? I find it really useful not just to talk with the doctor. In fact, it's almost more so to be able to talk with the nurses and the caregivers there who are providing the care. What does the individual need help with? What are some of the challenges that they're facing? And to go into physical and occupational therapy and just see what's happening is so helpful. So that I also have an idea, they really are having a really challenging time doing X or doing Y. And then as a speech language therapist, really is that needed? If there's something cognitive going on, if there are swallowing issues that are happening, things to ask about, is it possible to get a consult with any of these individuals? I also put on there the to-go bag, because, it is important to have just this bag that you can grab. And again, if you're being whisked away and you're not conscious, that's a whole different story. But if you have somebody even who could walk into the home and pick up this bag, it might make you a little bit more comfortable at the hospital. I once attended a Red Cross. I have friends who have worked for the Red Cross for their whole career or with FEMA, and they always have their to-go bag packed. And during one of the conferences that I attended with them, the EMT individual or the Red Cross representative said, when an emergency happens, you're taken out of your home the way you're taken out of your home. So if it's the middle of the night, think about what everybody's wearing. Maybe not much. So do you have tennis shoes even? I mean, just some of these basic tennis shoes to participate more easily in physical therapy. Um, just being able to grab that or point somebody to that, even that, robe to keep you a little bit warmer in that hospital gown. So again, many ways to advocate, many ways to provide support. So now, of course, is the next step that happens oftentimes, and it's time to be discharged to subacute care. As I mentioned, just heading off to nursing and rehab. The plan is always to discharge on a Friday, and I'm being tongue in cheek. Of course, that's not the plan, but that can be what often happens. Oops, I'm sorry. So, and of course, in this area, we have a daughter who lives in Virginia. The person we're discussing lives in the district, and the discharge social worker is suggesting a Maryland facility. This is kind of typical. Maybe not always the third jurisdiction wrapped in there, but I live over in Virginia, so I'm gonna keep it in here. And we do have a lot of Virginians who work in the district. So where should he go? What's the best place for him? The discharge planner is going to do the best that he or she can. She's going to do this based on availability. You also need to be able to communicate what your thoughts are. One of the places to start, again, before the crisis, you can't do this in the middle of it because things are happening too fast, is to know kind of, well, what's the care you're going to get in each of these places? And Medicare.gov does have a rating system. You can look up all of the nursing and rehab buildings and see how they're rated. There's a 5-star rating. I actually recommend people don't look too much at the stars. It kind of gives you, I guess, a good direction to look in, but you really need to dig down into the reports. Every skilled nursing facility has to, or nursing home, will have some sort of a review that's done, or if any complaints have come up. And I always think it's a good idea to delve into that report, see what's there. The other thing is this a situation where somebody may need to stay there long term? In which case we're talking about Medicaid. We may be talking about Medicaid long-term care. Not every rehab will accept DC, Maryland, and Virginia long-term care. So if that's something that needs to be in the back of your planning, you need to know if that community or that facility is going to accept that Medicaid. With the discharge on Friday, it's really pushing to ask if it can be done on another day. People are short-staffed on the weekends, so it usually goes smoother if it's another day. Sometimes you can't really do much on that, but it's something to ask about. And if you feel that discharge is coming too early, it's important to talk with the ombudsman. It may be that the decision can be appealed. With regards to which jurisdiction it should be in, again, being in person is so valuable. So if you have a support team who lives in Virginia and works in Virginia, then think about going to Virginia. Don't leave it out of your mental thinking about it. If you live in DC and your support network is in DC, then let's stay in DC if at all possible. But you have to be able to talk about what fits your needs best, and explain that to the discharge planner as well. And again, this is when it's nice to have somebody who can speak for you. The other thing is when you actually go to the nursing facility, make sure you're clear with the facility where it is you want to return to and what does that look like. The nice thing about subacute care is they're set up to rehab you. They're set up to get you back on your feet. So they have a big gym there that you can practice different things. So for example, if you have stairs to go into the home, they'll start you on the baby stairs, trying to get you up there. I've even been in places where after you graduate from the baby stairs, you go to the stairwell and you practice if you have more than 3 stairs to get up to your front door or to get into your full bathroom, which is, in this area, the full bathroom is always on the second floor. It's never on the first floor. So we need to practice doing that. If the other thing is, oh, I just lost my train of thought, so it'll come to me in a moment. I saw a question about disputing charges come up, and that distracted me, so I will go ahead and go back to that. You can what's called appeal. If you feel like a discharge is not appropriate at that time, you can appeal it and go through that process. Again, speak with the ombudsman, speak with the discharge planner. I think this is a good place just to stop briefly and see if there's any more questions before we go on to our last scenario and then wrap up.
Let me tell you, Christine, there are so many great questions. I say just power through the next slide, and then we'll get to all of them. And hopefully, can you hang on for maybe 15 minutes after the hour? Because I think it'll take us a while to get through everything.
Okay, sounds good. Then I will
Awesome.
quickly go through the
That,
last slide and
yeah.
wrap up.
Thanks, everybody.
Okay, so of course the last piece is how do we get you back home? What's going to be needed there? So this individual was told that he could return home following the rehab stay. By the way, I should add that Medicare typically pays for 20 days of rehab, paying for the entire cost of it. Most insurance are based on Medicare, but that's one reason why you need to investigate your own insurance. But that's only if the individual is continuing to improve. If the individual that you're supporting refuses to get out of bed, then they will probably be discharged pretty quickly back to the home. Again, safety is paramount, so that's the main thing that we often say to people is this going to be a safe discharge? And if it's not going to be a safe discharge, keep reiterating, this is not a safe discharge. So this gentleman said they can go home, but he's been told he's going to need 24-hour care. And the staff have said that he's going to need several pieces of durable medical equipment, which we call DME. And he's going to need an order for outpatient in-home physical therapy and occupational therapy. And of course, you always follow up with your primary care provider within a week, and you get new prescriptions. So starting from the top down, safety is really key here. That's one of the reasons why 24-hour care is often suggested. This is why it's important to describe what's happening. Are you going to be moving into a home where maybe you're moving in with a family member for the first week or two? So somebody's actually going to be there overnight. Overnight tends to be the big piece. Or do you have the ability to do a respite stay in an assisted living facility where you can stay for 30 days, and they may even have, most places do have a physical therapy group that's coming in and can provide you that. And some even have a nice little gym. So it's a little bit better than what you would get at home, because at home, they're just going to use what they can carry with them or you have available in your own house. Whereas in a gym setting, they might be able to do some fancier, more kind of inpatient as opposed to outpatient, even though it's outpatient. Um, so I often tell people, 24 hours is not necessary, is not going to be for the rest of your life. It's just to make sure that you're safe. And often home care companies will have some sort of a package that you can purchase, which would include the trip home, maybe a couple days or at least the day of some intensive care to make sure you're settled, make sure that the food that was left in the refrigerator, 6 weeks ago is no longer there. And that new food is stocked and in there and ready for you. This is where some of those lots of helping hands or Caring Bridge might be good to places that have the calendar to rotate those meals and visitors coming by. Ask if a small part of like a few days of your medications can go home with you. Do you have somebody on the other end who can pick those up? If your DME equipment is something that you're going to need someone to have it delivered to at the home, do you have somebody there who can open up the door for them, make sure it gets set? Do you know if insurance is going to pay for those things? For example, something like a wheelchair or even a walker. First of all, they're going to be the very basic model. So you need to decide, does that really fit what you need? And have you already had that within the past 5 years? Because then they aren't going to give you another one. So if you had an incident where you needed something and then you got over it and you gave it away because you didn't need it anymore, you're not going to get it completely paid for by Medicare. So understanding kind of what does your health insurance pay for? If you have Medicare, what does your plan pay for? What are your options for rehab? And don't just look at what's the one right down the street, but think about where you're going to have somebody coming in. Again, the way that our healthcare system works, it's really important that somebody be with you and in person, hearing what you're hearing so that you can review it together. Like I said earlier, sometimes you hear it in the moment and then just due to pain and everything else, you don't know what they said or you can't repeat it verbatim. What does Medicaid pay for if you're going to need Medicaid? In like long-term care setting. Again, Medicaid is for very poor individuals. It's different in every single jurisdiction, but I tend to think about it being less than $4,000 in income monthly and less than $4,000 in savings. And that's just that piece, not even looking at assets. Do you have long-term care insurance, and how do you get that started? It doesn't start automatically. Most of them would pay for a big chunk of the caregiving services coming into your home, but not until you've had a 90-day exclusionary period. And again, you want to check that. I've had some clients where the first time this happens, they're set for the rest of their lives. And other times where that's certainly not the case. What are your rehab options? Are you going post-hospital, are they saying go straight home, or are they saying go to a subacute inpatient setting? What are the options if you choose not to do that, and what are the pros and cons of that? And these are certainly questions, again, you can talk with a care manager or another professional. It's also good to talk with the social worker in the hospital as well. What about a respite stay or some home care? So then when the crisis is over, how do we recalibrate? How do we kind of reset things so that this doesn't become something that is chronic? Again, we cannot physically, mentally, and emotionally maintain the chronic piece of it, nor financially. So, is this a new norm, and what needs to be changed in order to mitigate those risks? Another piece of it too is acceptance and not letting some of these big emotions overcome you so you can't move forward. You may need to think about talking with a therapist about some of these things. What's some of the feedback I always go to my team when giving some of these talks, and one of the things that came up with is the fact that sometimes you're so angry or you're so depressed, or maybe you're feeling guilt. And again, this could be the person that all this happened to, because you think, darn it, I shouldn't have stepped on that stool. I knew I shouldn't have stepped on that stool. Or you could be that supportive care partner who's saying, I just left the house for a minute. So letting go some of that guilt, some of that anger, and setting it aside. Uh, Also taking a look at the changes that need to be made. I keep talking about the financial aspects of this, and we've definitely touched on some of those as we've gone on. I mean, 24-hour care itself is extremely expensive, and it's not going to be paid for through Medicare or other health insurance. That's health insurance isn't here to take care of things like bathing and dressing. Or cooking meals or doing your housekeeping. That's what a caregiver, a home caregiver does, but that's private pay. There may be some programs that could pay for it through Medicaid, but they take time to get into. And again, you have to be Medicaid eligible. Long-term care insurance we talked about. There may be options through the VA aid and attendance, but again, these are things that you need to be thinking about ahead of time. Also bear in mind that some of these big things that changes that may need to happen with your home so that you can stay there, if you're doing it while you're in the midst of a crisis, you're not having many options. You're going to have to go with what's offered for you. So widening doorways, making things more accessible is going to be a lot harder and a lot more challenging if you're doing it. Even doing things like sorting out the clutter that's in our home so that we have the clear spaces can really be a challenge. So keep all those things in mind as you're recalibrating. So thank you all, and thank you, Steve. I'm sure there's a lot of questions. So are there any final
Yeah,
questions?
no, I knew there would be because we have tons of people per here. Several hundred folks are tuning in. So let's dive in to these questions. And like I said, folks, I know some of you budgeted an hour for this. This is recorded, and we'll do a really nice synopsis at proaging.com and try to address. We'll try to get in the next 15 minutes or so. We'll try to get through as many of the questions that we have. So Christina asks, how do you encourage family or other advocates to be present? This is a common problem, is that you sort of recruit your village, whether you're related to them or not, and people are hesitant to get involved.
Yeah, I think part of it is, again, breaking down those pieces that you need, especially if you don't have any family. Um, what is your small village able to take care of? What pieces are they willing to do? And to have an honest conversation about this. This can even happen with families, I find. And I'm going to give you this example, which is family oriented, but kind of put it on the friends and neighbors as well. My grandmother lived to be 94 years old. She had 36 grandkids. I never lived close to her, but I wanted to do something for her. But of course, my parents and my aunts and uncles all said, no, 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 this is our problem. So I kind of had to make up my own thing. And I would send my grandmother money to get her hair done on a regular basis. So people want to help, but it's understanding what's not going to be a burden on them. And I do hear both sides. I hear the older adults saying, I don't want to be a burden. I don't want to depend upon them. I hear some of that from children and family and neighbors, but I also hear, but I want to help. So it's being able to clearly define where can you do this. It may also be hiring a professional. Have hire a care manager or somebody similar who can kind of be that, you and I have gone through these terms before, the quarterback, the captain of the team, helping assign some of those roles, even using things like Caring Bridge or lots of helping hands to kind of delineate what's needed and who's available. Because it is really important to have somebody there to be able to take notes, even if it's not the whole time. You and I both know you could sit for 8 hours and not catch the doctor.
Oh yeah,
um,
yeah, for sure.
so,
And Jonathan in the chat said, I'm a 79-year-old solo ager with no support network. And since my wife died, I recently hired an aging life care manager in advance of needing them to help me with my crisis planning. And so I know, Christine, that you and your practice are probably getting more and more calls like Jonathan, correct?
yeah, we are.
It's
And I
great.
think every practice is.
It's amazing because like a lot of times, folks, I know there's a lot of solos on this call. A lot of times you look at your friends with kids and grandkids and you're sort of like, oh, they've got this safety net. But quite frankly, most of the time they haven't had conversations, and having these conversations are what's really important. Um,
Yep.
I shared this in chat. Kathleen said, as an advocate, her secret weapon is to paste key parts of the doctor's report into ChatGPT. And Kathleen, with AI, that's a great use of AI. But remember, with everything, folks, uh, you got to just make sure to confirm with your healthcare provider. But it can provide you with some dialogue to have with the healthcare professional when they walk into the room next. Um, Okay. This is a good one. Christina says, doctors, nurses, doctors and nurses don't do screening even to know if the client is available to make decisions at the time that they come in. They may have had capacity up to that point. Everyone should have an advocate at a hospital. Um, uh, yeah, and I tell you, I mean, let's hope that in our lifetime we begin to see a cure for dementia and other conditions that innate cause us to lose our capacity.
Yep.
Um, let's see. Deborah says, I'm wondering how I can get my siblings to talk about all of this. I know I would have my sister and brother-in-law and brother as potential power of attorneys, but I think their fear of death and aging is so severe they won't even discuss it. They are in their early 60s and none of them want to have anything written down. This is not unusual, right, Christine?
No, it's not unusual. And sometimes having a professional kind of guide those conversations is a way to do it. Sometimes it's waiting for that opportunity. Even hopping on the back of something else that has happened, some news that's come out, or maybe a distant family member, maybe something's happened with them, but just to say, hey, I just heard what happened to great aunt so and so, and I really want to talk about this for us. Or if somebody has a new diagnosis, those are kind of times to say, I want to be prepared, and keep at it, keep trying. But you also have to be, again, setting out those mattresses while you're waiting for people to be ready for that conversation.
All right. Now I'm going to read Diane's question, and again, Diane, because I've been running all of this um, all of this, these solo aging discussions, this is very common. You are not alone in this. She says, I have no family to help, neither neighbors or not close friends. It feels like it's an imposition on people. What's left to do? I plan to add age at home as I can't afford a CCRC. Christine, I'm interested in your comments, but a couple of things on this, Diane, just to share with you and everyone is number one, what I tell everybody is lead in with what you can do to help others. That can oftentimes open up the doors to these mutual relationships. If there's a village, the age in place village in your community, definitely something to join. The other thing about CCRCs that I will mention, big fan of CCRCs. Those are communities that have independent assisted and nursing all in on one campus. Diane, consider looking into an independent living, senior living community. There are many affordable ones out there, like Friendship Terrace and Seabury at Friendship Terrace. And even though you don't have the healthcare on site, you're now close, you're in close proximity to other people that are in the same boat. And oftentimes that's the supportive village that we need, and it's more affordable. Um, any thoughts or ideas for Diane, Christine?
Yeah, I mean, you took the words right out of my mouth on some of those
Sorry
things,
about
but
that.
no, no, no. Um, but I do think looking at other options, I mean, understanding again, looking at those villages, now is a good time. Looking at the independent living and making your own community out of that. I think in this case, obviously I don't know exactly what the situation is, but knowing, okay, well, what would it actually take and cost for me to stay in my own home? And is that realistic? Um, if I live in a 3-story brownstone, am I okay with moving the commode into the dining area and the bed into the dining area and calling it a day? For some of my clients, that's the boundary. Like, no, I'm not moving into my dining room. For other people, they're like, that's the reality. That's fine. I'm good with it. But you can make the community, you know, if you're in an independent living and it's an affordable independent living, um, you can build new community and just start making those contacts. Get to know who's out there.
Okay, let's see. Okay, and I'm dropping the Aging Life Care Association website on into chat. Several questions on how do you find an aging life care manager like Christine. Okay, let's see. Okay. It, if the plan is to age in place, working early while you're healthy and calm with an aging in place certified architect. Yeah, really, folks, if your plan is to age in place, so many times people say, I want to age in place, but they don't map out a plan
Yeah.
that handles, if I can't drive, what am I going to do? If I can't get up and down stairs, what am I going to do? If I outlive all my friends and family and neighbors, what am I going to do? That answering those questions is how you can create an age in place plan. Um, okay. Eh, Sorry, I'm just scrambling through here.
Big
Barbara
topic.
says, Barbara says, does anybody know of a checklist for preparing for a crisis like the ones described? Um, uh, do you have a guide? You know, the interesting thing about this, Barbara, when I download this recording, I I'm going to try to see if I can play around with some AI bots and create a checklist like the one that you're describing. And we'll post that at proaging.com with the recording. I kind of feel like our conversation is walking us through a checklist.
Mhm.
Um, let's see. Okay. Uh, okay. Al says there is a patient's right protocol standards for facilities that take Medicare, Medicaid patients. If a facility does not take Medicare, Medicaid, what types of protocols are there? And Al, I dropped into chat. I did a little research while Christine was talking, is that all of the communities, whether they're Medicare or Medicaid, they have to abide by the state regulations, which is very close to the Medicaid, if not in exceeding Medicare, Medicaid standards.
Mhm.
Um,
And you can always,
uh,
every place will have, the ombudsman's phone number there as well if you need it,
oh,
just to mention that.
Here's a good question that not an easy one to answer, but
Oh.
Sherry is asking, how do you choose a home care agency? Like, I mean, because you've helped so many clients find home care, can you give us any words of wisdom on some of the things that you look for?
Yeah, I look for good communication. I think that is the number one piece for me is making sure that they're willing to communicate, um, not just with my client, but with me, and allow me to talk with the caregiver as well. I think, for the if you're out there kind of searching, it's always good to hear from other people what their experiences have been. Um, it's good to talk with again an aging life care manager. Um, it's also good sometimes just to interview people if you can. Again, an agency will have vetted everybody, but it's good to understand, well, is this somebody whose personality I can get along with? You'll probably have to pay for that, but sometimes that's well worth it. Sometimes they're gone in a second. So it didn't matter, but at least it makes you a little more comfortable with it.
Great, great. Okay, Al gets the gold star for some really good questions today. But if a hospital has a patient in their facility for several days, but has the insurance code as observation, what's the best way to appeal to get that designation to admitted so that you can qualify for Medicare? Any words of wisdom on that one, Christine?
Um, well, again, I don't remember exactly how many days it is, but I actually think it's 3, but they can only have you under observation for a limited number of days. Again, for some reason, 3 is ringing in my head, but I would have to double check that. Um, I would talk with the ombudsman. Usually they can't change anything, but I would advocate, this might be in time to see if you can appeal something. Um, but again, talking with your ombudsman is always the way to go. But it may also just be having a conversation with the doctor, not necessarily saying you need to change me to inpatient and admitted, but talking about what the differences are, and why you're under observation and not admitted. Those are good ways to go. And again, sometimes even to the providers in the hospital, because you don't feel any different. You don't look any different. There's not a different section of the hospital. Sometimes if you ask the staff, they'll say, of course you're admitted. But when you look at the paperwork, you're not. So it's important to look at the paperwork, and they should be having that discussion with you. But again, somebody could have come in and tried to discuss it and left the paper meaning to come back. And that's that.
Yeah, and just asking that simple question to as many people to confirm that you're admitted and not under observation makes you a great advocate for yourself or your loved one, and they're gonna attention is gonna be heightened. There was an earlier question, I think you answered it, but I just want to double check that because I've seen this in several situations where somebody's in the hospital and they've got a medical condition and they're like, oh, it's time for you to leave, and now you got to leave this environment with all the great healthcare and everything like that. They talked about disputing a discharge. Is there uh have you ever been involved in a situation like that, Christine, where it's like this person is not ready to go yet?
Yeah, definitely. And again, that's when you file an appeal. what I keep, again, sometimes it is that repetition over and over again to indicate why this is not a safe discharge home, talking with the ombudsman, talking with whoever will listen, and then making that formal appeal to dispute the discharge. And you know, again, sometimes the timing is a little bit off, but sometimes this is where we might even be appealing, no, you know what, this is not a safe discharge home, but this would be more appropriate to go to a rehab facility. So it may not even be just the discharge, but where are they discharging you to?
Yeah, and we know how most people react when they're told that they can't go home or they shouldn't be going home, that they should be going to a nursing and rehab center.
Right.
Um, that can be the reverse situation. Okay. Um, Tom asks, does Medicare pay for expenses while under observation? And Tom, I did a quick search, and they do because you're in the hospital if you have Medicare. But Christine, any thoughts on that?
Yeah, I would just confirm, you know, it's a different setting because the observation is not considered to be inpatient. So it's really more of that outpatient, so the Part B section. So understanding what you're paying for under the outpatient versus the inpatient, or
All
what
right,
they're paying
and
for, excuse me.
I think we're down to about uh, we've done an hour and 15 minutes, and we want to give Christine a break, but let's finish on this one because I think it's Susan says, is the ombudsman always available in an emergency situation to help? Where I live, they're volunteers and not necessarily available. That's been my opinion too. I mean, my experience too is that most ombudsmen are not available in an emergency there, but they're great at advocating for you if you can't come to an agreement. What are your thoughts, Christine?
Yeah, I would say the same thing that you know, this isn't necessarily an emergency situation. So again, that's why it's important to have somebody there who's asking these questions ahead of time. Um, Keep in mind, I mentioned during the talk that, you know, almost the first thing you learn in social work is document and then discharge. So people are going to start talking about discharge almost as soon as you arrive, particularly in a hospital, not so much in the rehab setting, which I would also consider to be, I mean, that's a medical setting, and there's an ombudsman there as well. So this isn't really going to be a surprise. So you need to continue asking those questions. Jot down the ombudsman's information first thing, or you know, a couple of days after. If they're saying, oh no, they're only going to be here for a couple of days, well, that might be the time to jot down that number and start asking more of those questions.
Man, Christine, this has been great. It's a wonderful way to kick off 2026 uh,
It is.
with a
And the
huge
30th year.
turnout and an important, thought-provoking topic. Is there anything that you didn't share that you'd like to make sure that we close on today?
Really just reiterating that this might be the time to, you know, hire a professional. Again, somebody who's a little bit more objective can step back, take that larger view, even if it's for a short period of time, because, you know, hiring a professional, it's a cost of money. So can it just be for now, even to give you that distance and to start some of these things in motion?
Yeah, and folks, I mean, I don't want to monopolize Christine or any of her colleagues' time, but most of the time, the aging life care managers, patient advocates, they all have an initial consultation to just make sure it's a good match. And you talk to, two or three, you'll begin to get a vibe if of somebody that you could see or an organization advocating on your behalf, and you'll learn a lot. Just kind of, they're almost like these webinars. each of them may share some different things that you didn't think about. And
Yeah,
so I highly recommend that.
so
The
much. You can't cover it all in an hour. Can't
Yeah,
cover it all in a lifetime almost. So,
all right. Well, thank you everybody for tuning in. I'll try to get this recording up as quickly as I can. And
thank you.
Christine, thanks so much. I'll make sure all your contact info is on that recording link. And congrats to the anniversaries with Seabury.
Yeah, thank you. It's exciting. So, thank you so much
All
for
right.
allowing us